Okay. All right, so you looked at this patient, they're 72, a male, they had a stroke, and then it's telling you that they have some residual or leftover complications from that, and they had left-sided weakness. Okay, so usually one side or the other becomes weaker with the stroke. Okay, other history, type 2 diabetes, which we already talked about, how that blood sugar being out of the normal range is going to delay healing. And then hypertension and obesity, which we know both play a role in perfusion and circulation and just the health of all of our organs in our body. Right, and then our medications, some of those should start to be sounding a little familiar to you. So that metformin, that goes directly with the diabetes. It's an oral medication, right? And it's just for type 2. So if they're type 1, they only take insulin, right? So, but if they're type 2, then the oral medications can work and can help them. Okay, and lisinopril is our blood pressure one. That's one of our ACE inhibitors, is one of our subcategories. Okay, and then aspirin. Why do patients take aspirin? Heart health. Yep, perfect. Yep, heart health. Okay, it's a mild blood thinner. Okay, and then this patient doesn't have any allergies. The situation, he was admitted to the med-surg unit 3 days ago, and then his specific stroke that he had was an ischemic stroke. So we've been talking about that word, ischemia. It means a lack of perfusion, of oxygenation. So what's the opposite of an ischemic stroke? Anybody come across that in their reading or anything? Kennedy? Yeah, hemorrhagic. So usually if your patient has a stroke, it's usually ischemic or hemorrhagic. So there's a clot in there that's cutting off perfusion, or there's a bleed, and where that blood is leaking through, oxygen can't perfuse. Okay, good. He has limited mobility now on that left side. He's requiring assistance with repositioning. On your morning assessment that you do, you look at his right heel. You notice that it's red and it does not blanch, okay, which is a key term for figuring out what stage our pressure sores are in, which means stay white. It does not stay white. The skin is intact, but feels warmer than the surrounding tissue. So there's some like inflammation going on. Okay, his vital signs are stable. His temperature is good at 98.7. His pulse is good at 82. Respiratory are 18. His blood pressure is okay, 138/76. And then that blood glucose, not horrible, but still higher than it should be at 158. All right, so our questions here, and we're gonna start with Audrey. What potential problem is developing with Mr. Carter's skin? Yeah, pressure sore is mainly what we're worried about with this patient. Anybody come up with anything else or identify what stage pressure sore we're looking at? Taylor? Yeah, so stage 1. So that's the definition of a stage 1 pressure sore. It's non-blanchable redness. So there's a red spot on an area of high pressure. So like the heel is a common one, if they're just laying on their back. So it's red. If we press on it, if it's still got circulation and it's just red like you or I, if you're sitting with your legs crossed in lecture, if you uncross them, it's gonna be red, but you don't have a pressure sore because if you push in that red spot, it'll turn white, which means that those blood vessels are still perfusing. They're not collapsed and dead yet. So when you push on them, it closes it off, and then the red comes back, and you see that there's still perfusion there, so it's temporary. So when it's non-blanchable redness, it's damaged. It's not red from pressure, and when you push on it, it's gonna shut off the perfusion and then bounce back. It's damaged. It's damaged tissue. It's dying. Okay, so non-blanchable. So if you push in the middle, it's not gonna turn white. It's just gonna stay red. Okay, so that tissue is no longer perfusing. It's not getting circulation. That's dead tissue. It's eventually gonna open up and become a sore, usually. All right, next question is having you look at those risk factors. So just kind of listing through what we've read about. In his scenario, Jasmine, what are the risk factors that you identified that put him at risk for impaired tissue integrity?
Immobility due to the stroke,
Yep.
age, type 2 diabetes, obesity, and hypertension.
Okay, good. All right, anybody come up with anything else. So we got immobility, diabetes, we got age, we got hypertension. Anything else? The use of aspirin, not necessarily in itself. Decreased sensation, yeah, so decreased sensation, so that's one of our factors on the Braden that we assess. Can they feel if they're against something that's causing pain or pressure? Okay, so decreased sensation, and then anything else that we missed? Yep. Yeah, decreased mobility, we got that one. Did we say obesity?
Yeah.
Okay, so we said obesity, okay, good. And then, nutrition could be a factor. All right, and then, so what nursing assessments are we going to perform, Erica?
Mostly assessment.
Yeah.
The rating scale,
Mhm.
nutritional, circulation, mobility, and
Okay, good, so assessing the skin, using the Braden scale, and then what are those signs that a pressure sore is developing? So as we're doing our skin assessment, what are we looking for that we know could mean that they're developing a pressure sore? Discoloration, redness, temperature? Yeah, temperature, so if it's warm, yeah. If there's edema, like swelling, I think we said that. If there's moisture, okay, so one of our terms was maceration. So if the patient is sitting in wet linen or wet gown, that's just gonna soften their skin and make it easier to break open. Okay, so moisture will be another one. Alright, and then number 3, we just did. Number 4, then immediate nursing interventions. Zol, do you have any of those nursing interventions?
Putting like a pressure, like a mattress on to help alleviate the pressure.
Okay, so maybe having a special mattress or protective layer over their mattress can help?
Repositioning them.
Yeah, repositioning, and the standard is every 2 hours, right? If they can't reposition themselves every 2 hours. Anything else, Leanne, you wanna add? Alright, yeah, just keeping that blood sugar in normal range, and then just progressing their mobility as tolerated. So while they're in the bed, we're gonna turn them, but try and get them out of bed as soon as possible.
Yeah, he calls it, it's one of those, boots, pressure relief boots.
Yeah, so that, it kind of goes along with the pressure relieving or like a layer of the mattress, but to prevent a heel pressure injury specifically, I know in clinical we had some that they have special boots. So instead of relying on their foot being positioned in the right place, their foot is always in the right place because it has that protection on it itself.
Just making sure that their skin's clean and dry, as well as, notifying health providers and documenting.
All right, and then the long-term interventions are really just gonna be more of the same thing, right? So the same thing that we're doing immediately, we're gonna continue to do long-term. We're gonna turn them, we're gonna increase mobility as much as they can tolerate. We're gonna focus on nutrition and hydration, if they need to take any type of supplements. If they are incontinent, maybe we're telling them about barrier cream that they can use to try to get ahead of this problem. Okay, so all of those long-term interventions. Okay, and then how will you evaluate if your interventions are effective? For Avery, how will we know if our interventions are effective?
Monitoring skin changes.
Yeah, just keep looking at that site. Is it getting better or is it getting worse? Are there any new areas developing?
And then asking the patient if it still feels uncomfortable, if it feels more comfortable after all the intervention.
Yeah, so factoring their pain into it if they're having pain with that wound. Okay, and then teaching is all gonna be repetitive of those interventions of the short term and the long term. So those are all the things that we're teaching so that they have to change position. If they're wet or sweating or saturated, they need to get those wet linens off and be clean and dry. Different mobility devices that we can hook them up with. And then just doing that skin assessment. So just being aware that there is a likelihood that they can develop pressure injuries. And so just that know. So that first category that hopefully is starting to sound familiar is basic care and comfort. So that's one of the categories of questions that you'll have. So are you aware of, what are basic comfort measures that your patient needs, and how would you help your patient meet those? Okay, so assessing for deficits in hygiene, mobility, and skincare. So specifically, it's up to us to perform those skin assessments. Often during bath time we can do it, or just during our head to toe assessment. To be aware of, and if we're not doing it, delegating the turning and repositioning of the patients. And you guys all know by now that that's charted with our rounding hourly. We can see how our patient is repositioned and turned. If they are incontinent, just being aware of that, managing it. Sometimes we can get ahead of it by doing a toileting schedule to prevent the incontinence, but sometimes it's just not preventable, so just getting in there or delegating for somebody to get in there and clean them up and make sure they're nice and clean and dry. And then definitely using that barrier cream if you have a patient who's incontinent to help that, make that extra layer of skin kind of like. Okay, and then hygiene for our patients with any wounds or rashes or anything like that. If you're in my clinical group, you may have seen me like bring the hand sanitizer over to the patient, because you don't always think, you're always worried about your hand hygiene. But if they have a wound or anything like that, if you think, a lot of patients are like itching and scratching and touching things. So if you're ever in the room and thinking about it, give them that hand sanitizer, or help them to the sink if they can get up, to make sure that they're not spreading any infection or increasing their risk for infection. All right, and then safety and infection control. So like we said, if we don't keep them safe and turn them and keep their skin intact, they can get a pressure injury. And then once their skin is open, we're worried about infection developing. And it can start as something local, like in a wound or a cut or an IV site, but we worry about it spreading and getting in their blood, and then that patient even becoming septic. Okay, so just protecting our patients from infections, from injuries, using sterile technique during wound care. So you guys have all had a chance to go through Foley care once, right? You guys have all done that so far. So even though we're not in an operating room or in like a sterile room, it's a sterile technique, right? Because the equipment that we're handling and all of that, we keep it sterile. Okay, so same thing with wound care. We can do it in our patient's room. We're not doing it in the operating room. But after we remove the contaminated dressing, once we're going to measure and clean and put on the clean dressing, depending on the wound, we'll use sterile gloves. So depending on your dressing, it could be a sterile procedure. Our focus this semester is pressure injuries, and pressure injuries are not sterile wounds, so that is not a sterile procedure. We would just use regular clean gloves. Still, I wouldn't open up my 4x4 and just drop it on the table, right? A 4x4 in itself is sterile until you open it and use it. So again, we're still maintaining medical asepsis and keeping everything clean. Just pressure sores are not a sterile wound change. Okay, and then applying our contact precautions if we do have a patient who's on isolation for an infected wound. Most common one that we're seeing these days, if you people who are in the hospital want to chime in on this, is MRSA, right? Is that still the main one? If they have a wound that's infected, it's MRSA. So methicillin-resistant Staph aureus. So we have Staph aureus in our body and on our body, but if it's too much or in the wrong place, and then especially if it's resistant to methicillin, now we have one of those drug-resistant organisms. It's really hard to manage and take care of, and then there's lots of complications for the patient. Okay, so you might see them on ISO for MRSA in a wound, and then MRSA can also spread. So it can be local, but if it's not managed, it can also spread into the bloodstream, and they can have MRSA as a blood infection as well. Monitoring for signs of wound infection. So we kind of touched on this, but like your redness, your swelling, your heat, your decreased range of motion, maybe decreased sensation, your purulent drainage. Okay, all of those are going to be signs of a wound infection. Okay, and then just being aware of our linens and dressings and all of those things as we're handling if there's any blood or body fluids. Just remembering our standard precautions. So even if they don't have a highly contagious wound and they're not on isolation, it's still blood and body fluid. So just always keeping that in mind. All right, and then reduction of risk potential, and you can easily see how tissue integrity falls into that. Again, just with skin integrity itself, and then infection. So So early detection, prevention of complications. So pressure sores is a main risk that we know that our patients can develop in the hospital, just like falls. So it's one of those things that we're constantly screening for and intervening for so that we don't develop a pressure sore. Okay, again, it's just checking for skin breakdown, monitoring for skin reactions to medications. So if it's something a patient's been taking for a while, we're usually not too concerned, but anytime you give a patient something for the first time, you wanna be on the lookout extra close, and then specifically, antibiotics will cause patients to have a rash or different types of reactions. Okay, so we might just see a regular rash, or Stevens-Johnson syndrome is like an extreme, system-wide reaction to an antibiotic. They can get a bad fever, rash, and then it turns into really bad blisters. So you might see that. Okay, and then specifically to post-op, so we'll just touch on the types of healing and the complications, but you'll focus more on like the operating setting, the operating room setting next semester. But we're looking specifically for those complications. If they have an incision, it should be approximated, which means together. There'll be glue or staples or sutures, whatever it is, but it should be all approximated. And when a wound is sutured or glued or stapled, it's about, give or take, 10 days for that to be healed. And then if there's sutures or staples, those would be removed after about 10 days, give or take. And then that should be enough time that those edges grow together. So as we remove the sutures or whatever it is, it's healed by then and it will stay in place. Okay, if it comes apart, there's an opening, that's called dehiscence. Okay, the most common place we see it is in the abdomen, right, because that's where we turn and bend and put all of our strain and pressure. So we could see that there. Or just delayed healing if they have poor perfusion, bad nutrition, diabetes, anything like that. Okay, so then just identifying those signs, the weak pulses, the cool skin, pale skin, or impaired circulation, and then the pressure injury signs are gonna be that red, that non-blanchable redness. All right, and then the last category is physiological adaptation. So remember that always means at the cellular level, what's going on in the body. So just knowing those stages of wound healing, knowing the type of drainage and what it means as you care for these patients. So we're not gonna talk about burns in this semester, that's like third or fourth. Pressure ulcers is our main focus. We'll touch a little bit on surgical, but you'll go more into that next semester. And then on NCLEX, you'll maybe see questions about psoriasis, eczema, fungal infections. Psoriasis, eczema, fungal infections, you'll talk more about those in your pediatric rotation, but they're all just like inflammation, irritation of the integumentary system in different ways. Okay, and then providing wound care in next semester, you're gonna go into diabetic ulcers, venous stasis ulcers. Okay, and then those complications like necrosis, so like the skin and tissue completely dying. Gangrene is like a really bad infection where they are to the point where they have to amputate. And then graft failure is like extreme, more to do with burn patients where grafting skin transplants. All right. On this next one, I have a couple slides here. I have 3 practice patients here, and I want you to just take out your Braden. So you have one copy of a Braden. It's kind of hard to see. A lot of words in a small spot. But just see, so for each of these, so for Mary and then the next 2, see where you would score them based on the information that you have. So go through sensory perception. That's their ability to respond meaningfully to pressure-related comfort. So just read through your choices. You may or may not have enough information and see if you give them a 1, 2, 3, or 4. Okay, and then for moisture, the degree to which their skin is exposed to moisture. So think of sweating or incontinence or their ability to move themselves. Activity is their degree of physical activity, so like getting up and walking. The one below that, mobility, speaks to their ability to change position in their bed or in their chair or wherever they're at. Okay, so activity is walking, mobility is changing position. Okay, and then nutrition kind of speaks for itself there if you read along. And then the last category is, do they have a risk for friction and shear, so as we have to change them and boost them up in bed. Okay, so, just go through these next three, you've got Mary, you've got Lucius, and you've got Sam, and just on the information that you have, see how you would rate them. They're high risk, low risk. Okay, and then we'll just kind of talk about the interventions down at the bottom. Information, we kind of have to read, and you can tell me what you thought, I'll tell you what I thought. Okay, so for this first one, sensory perception, I ended up putting 3. What did you guys put? Okay, so 3, response to verbal commands, because it doesn't say that she's not responsive. It cannot always communicate discomfort or ask to be turned, or has some sensory impairment. So just knowing that she had a stroke and she's bedbound, knowing the pathophysiology of stroke, I gotta say she's probably got some impairment. Okay, so I would say it's not a 4. I don't really have enough information to say she's 2, so I went with 3. Does that sound good for you guys? 3. All right, moisture. What'd you guys put for moisture? 2. I also put 2. I thought just based on the information I have, she's incontinent. We don't have a BMI. We know like if you're bigger, you've got folds and like moisture can develop under there. So we don't know. So I thought 2 based on the information that we had. All right, and then activity. What did you guys put for that one? Not 1, because it says she has increasing difficulty getting out of bed. So we know she gets out of bed. I was between 2 and 3, because it doesn't say when she gets out of bed, where does she go? Can she walk a little bit, or does she get right into a chair and stay there? Okay, so we would need more information. If she just got in a chair and that was it would be a 2. If she got up and did a little bit of walking, then she would be a 3. Okay, and then mobility then is her ability to change her position in bed. What do you guys think for that? 2, you think? Yeah, I'd say probably 2 based on what we have. And then nutrition's a hard one because it doesn't really say anything about what she's eating. So we could make a guess, but again, we don't know. We know if she's not eating, she's at a higher risk than if she is eating, right? And we know if you have had a stroke and you're dependent on mobility and things like that, are you probably hungry and worried about eating? Probably not so much. So without more information, I can guess that she probably has a nutrition deficit, but we don't have that info. Okay, and then friction and shear, what'd you guys put for that? I heard a 1, anything else?
2.
Maybe a 2? Okay, for this one, I put 1, just cause she is bedbound, she is incontinent. Okay, so requires moderate to maximum assist moving. I would say that sounds appropriate. 2, it says, moves feebly or requires minimum assistance during a move, skin probably slides to some extent, maintains relatively good position in chair or bed most of the time, but occasionally slides down. 1 is requires moderate to maximum assist in moving, complete lifting without sliding against sheets is impossible, frequently slides down in bed or chair, requiring frequent positioning with maximum assistance, spasticity, contractures, or agitation leads to almost constant friction. Okay, so again, I'm kind of in between, we don't really have all the information. Okay, so you would add all those up, and she's gonna be at least a mild, moderate risk, and then below that are your interventions. Okay, so all the way on the left of your scale is good, they don't need any equipment, just if they're a patient, we're just gonna let them know, hey, while you're in here, like, don't lay in one spot, change position, and we're gonna be checking your skin, because that's what we do. Right, once you get into the mild to moderate, now we're starting to add some interventions. It talks about maybe a specific mattress or an air overlay, maybe a cushion if they do get up to a chair or a special device to sit in, make sure it has a special cushion. Bed cradle or gooseneck, those are the things that keep the foot, the bedding and the sheets off their feet to keep them from smashing down. Okay, it's just like a little bed cradle. Okay, and then what we're gonna do, we're gonna reposition them, we're gonna promote activity, continue to assess for all these factors, and then continue to evaluate. Okay, and then for high and severe, it's really pretty much the same thing, there's not really anything extra on there. Okay, all right, let's do our next one here. So for Lucius,
I have a question.
yeah,
Sorry.
no, you're good.
Okay, so 4 is considered, not too bad, and then 1 is considered like bad.
Yeah, so on this scale, for the ones that have a 4, that's like good, like no deficit, no impairment, and then 1 would be the worst.
Okay.
So like completely limited, yep. And then every place that you have to document on this, on your patient, there's always a key. So in Epic, as we go through and fill it out, if we click in each column, there's that key off to the side, so it can kind of remind us, you know, we can kind of think where our patient falls in there. All right, and then we've got another patient here. This is not uncommon to what we'll see in the hospital setting. He's 52, he's got the diabetes, he's got the circulatory problems, he had an abdominal surgery, he's in the critical care unit, he is slouched down in his bed, his abdominal dressing is moist, only part of the tape is adhering to the skin, his level of consciousness is decreased, and he responds only to moderate touch and pain. Further assessment reveals the beginning of a pressure injury on his heel. Alright, so going through this one, looking at sensory perception, it says he only responds to moderate touch and pain, so that's definitely a deficit. So we're looking at a 2 for him. You guys agree with that for sensation? Give him a 2. Okay, and then moisture, at least with the information that we have, I would say probably a 1, right? With him, he's got like sweating going on, his
abdominal dressing is moist. Is he sweating or did I make that up? I made that up. Okay, again, with his level of consciousness being decreased, impaired sensation, we don't have all the information, but just based on what we do have, I would say 1 for him. Okay, so things aren't looking good for him. He needs a lot of attention and hands-on care. Activity, he's a 1, right? He's bed rest, doesn't say anything about him getting up at all. Mobility in the bed, completely immobile, right? He's slouched down, so he can't boost himself up. Nutrition, do we have anything about nutrition on here? No, but again, if he's decreased level of consciousness and all those things, it's not like when you bring his tray, all of a sudden he perks up and he's alert and all those things. So we don't have all the information, but it's probably not good. And then friction and shear, definitely a problem, so we're gonna have to boost him. We're gonna have to move him in bed. Okay, so he's gonna be a high risk. And then our last one, we'll go through and see if we can come up with a Braden for Sam. He's 56. He's here for aggressive treatment of a bone infection. So he had an infection that got so bad that it went to the bone. Aggressive treatment means like really strong antibiotics. And when you take antibiotics, they don't just kill the bacteria, but they kill all your cells. So they can decrease your white count and red count and platelets and all of those things. Okay, he's not responding to usual treatments. He's 5'4" and weighs more than 300, so I'm sure that's a really high BMI. So we've got obesity. He tells you last time I was here, my skin got really irritated and developed several wounds. So some people, even if they don't have like allergies or specific rashes, some people just have sensitive skin, like the tape and things that we use can really irritate them. All right, so sensory perception, we don't have any information that says if he has numbness or tingling or anything like that. So with what we know, he's probably a 4. It doesn't even say if he has diabetes or anything. So we know the kind of questions we would have to ask, what we're looking for to make him lower on that scale. But just with what we have, we'd have to give him a 4. Moisture. And again, it doesn't say anything, but we can see the risk factors with his BMI, with his need for antibiotics, since he's had a reaction before. So just with our information, we can't score him bad. We'd probably have to give him a 4. Okay, but we would know more questions to ask. Okay, activity. Okay, it doesn't really say. We have to see if he can get up, dangle, walk. Okay, and then we can score him on that. Mobility, again, as you're caring for him and doing your rounding, seeing if he can follow direction and turn and all of that, or do you have to do all the work for him? Okay, and then nutrition, we have to assess his diet, right? See if he's taking any supplements. A lot of times if you're really sick with an infection and taking antibiotics, that really affects your appetite. So it could potentially be a risk. We could see those risk factors, but we don't have the info here. And then friction and shear, again, he does have a high BMI, but we don't know what his mobility is. He's still relatively young, so even if we have some chronic conditions and bad lifestyle choices, we might not necessarily have caught up with him yet, so he could still be relatively mobile. Okay, so those are the parts of the Braden. We do those with each of our head to toe assessment. Okay, and that's our focus with this content. All right, these first slides then we're gonna go through our vocabulary. There's some nice images here for you. Some of them are pretty gross. So this first one is an abscess. Okay, so you might identify abnormalities on your patient, and one of them might be an abscess. Okay, so it's a collection of infected fluid that has not drained. Okay, kind of like a large version of a pimple, right? Okay, so just a collection of infected fluid under there, an abscess. Okay, so some of them you can see there's like a white head to it, other ones are just all red. Okay, so if your patient has an abscess, that means infection, so they're gonna be put on some type of antibiotic, depending on the type of bacteria and how severe it is. Could be oral, could be IV, and then again, depending on the severity of it, they might need to have what's called an IND, or an incision and drainage, where the surgeon will go in and slice this area open and drain all of that out. Okay, so I still remember one of my first, like, in my first year of nursing at Marion General up on 4 South, we had a patient, very large man, So him and his assistant and me were in there, and he set up a sterile field and just sliced that baby open. He had a biohazard bag on the side of the bed, and all this blood drained out, and it's crazy, there was blood all over the place, so. They can do it at the bedside, or they could do it in the operating room, it just depends on the surgeon and what's going on with that patient. So they'll clean it all out, depending on the size and the extent then, maybe they'll just leave it, maybe they'll put a bandage over it, or if it's like a really large abscess, they'll put, like Kerlix or like rolled gauze in it and leave a little tail out of it as like a drain, so that area can continue to drain out, cause if not, a new abscess will just develop in that cavity. So that's an abscess, right? Anybody see those in clinical yet? I think we
I actually had
You did have
a
one?
finger,
Oh, yeah.
I ended up slicing
Oh, boy.
accident, and I was cleaning my tires, and the bacteria from my tires
Yeah.
got into my
Yeah.
hand, and it kept growing and growing, and they sliced it when I was in the emergency room.
Yeah, yeah, so we tell patients, don't do it by yourself, and don't handle it on your own, because you could get infection, right, with whatever you use to lance it or open it up, so. And you'll see that a lot of times, the patient that you'll have, they had an abscess, they tried to manage it at home, and then it got infected, and then they came in. Okay, and then in Marion specifically, you might see, like drug addict patients who are injecting, and then those sites become abscessed and they get infections, so you might see that in Marion. Alright, some new vocab here, bandage or dressing, those are used interchangeably, and that just means whatever is on the wound, okay, a bandage or a dressing is what we call it. So just some different equipment over here, this one on the bottom left is that rolled gauze, or Kerlix we call it, with a K, K-E-R-L-I-X, and it's just rolled gauze. So we would have something underneath that usually, and then we just wrap it, and then we can cut it and then tape it to itself, so we don't have to put tape on that patient's skin. Okay, so that's Kerlix or rolled gauze. And then over here, you can see, I can't tell if those are 2x2s or 4x4s, but 4x4s we use frequently to clean the wound, and then as a dressing itself also we can use, just depending on the wound. And then on the right, that's like a type of Tegaderm with gauze, so it's like the gauze with tape built in, all in one. So the center of the dressing is absorbent, and then all around it, the border is the sticky part. Okay, but if you just have gauze and tape, same thing. Okay, up on the top is just your regular old Band-Aid. Okay, there's all different sizes and shapes of those. And then up on top is tape that looks like plastic tape, and there's paper tape, plastic tape, cloth tape, there's all different types of tape. Usually we use plastic tape for everything because it sticks the best, but you might have patients who are like sensitive and you can only use cloth tape on that, so you'll have time to explore all the tapes. Okay, and then up above that, it looks like an ACE wrap, but it's not an ACE wrap. An ACE wrap we do sometimes use as an outer layer to keep the dressing in place, to pad and protect, and also to add compression if there's like swelling to promote that venous return. But this is Coban, and it's like an ACE, it's kind of like a combination ACE wrap and Kerlix, but it sticks to itself. And you may have seen like lab techs always use these, and they're usually red, but they can be all different colors. And like I said, it's just like a Kerlix that sticks to itself. So you just wrap it wherever you want to wrap it, it sticks to itself and you cut it off. You can use it and wrap it like tightly for pressure, or you can do it loosely just to keep it over that dressing. Okay, and it sticks to itself, and then that would be your outer layer of that dressing. All right, and then biofilm, a thick grouping of microorganisms. So we talked on one of these further slides, you'll see slough, S-L-O-U-G-H, which is just like dead tissue. So as you have a wound, your white blood cells go to that wound and they eat things up and clean things up. And as a result, there's like dead tissue, dead skin. And with each dressing change, we clean that away. Well, some of that dead tissue can get really sticky and stringy, and it's called slough. And if the slough isn't removed, then that slough can develop biofilm, which is just infectious agents growing in there. Okay, so it's biofilm and slough, they're kind of used interchangeably. Okay, it's just gross, yellow, stringy, yellow or white debris, and we need to get it out of the wound so that new granulation tissue can grow. Okay, so might see in the wound, it needs to be cleaned out. Alright, debridement. So on the future slides, you'll see normal saline, our 0.9% or isotonic fluid. That's our main wound cleaner. That's our wound wash. That's what we use for all of our wounds. And some of the slough and biofilm with saline and gauze, we can get it on there, but sometimes not. So we need to debride or remove that dead tissue. This is a picture of mechanical debridement, so like using a tool, a mechanical tool, like a scalpel. So in this situation, a physician or a provider would be doing the debriding, and there's black or necrotic or dead tissue. So it was ischemic and then became necrotic, so they're cutting it away, they're debriding it. Okay, and then you'll also see, once we get, probably not till next week, but the different types of dressings and things that we put in the wound. There's different like creams and foams that kind of dissolve in there that can chemically debride. So there's parts of our wound care orders that we're putting on just that dead tissue that's supposed to chemically debride it and break it down. So when there's multiple creams or even any one cream that goes in our wound, we wanna make sure and stop to look up what it's for. Cause if it's to promote moisture and wound healing, we wanna put it on the red tissue, the beefy red tissue that we want to grow. If it's a cream or something that's gonna cause tissue breakdown, like for our slough and our dead tissue, it only goes on the yellow tissue. Okay, so just always stopping and looking at, because our different creams can do different things in our wound. Alright, and then here's a picture of our dehiscence. So that's the separation of the wound, so it should be approximated or together. Dehiscence means it comes apart. So this top one, you see, there's just a small suture line. Looks like there were 4 or 5 sutures or staples already removed, but then there's just that one little area where it dehisced or opened up. Okay, and then these two are both abdominal wounds. So this one over the side, you can see it's a vertical incision, and it looks like it's kind of been healed for a little bit and then opened up. Okay, and then that's the abdominal cavity underneath those tissues. And then here you can see it opened up on this transverse or horizontal incision. Okay, so that's dehiscence opening. And then I have a little picture down here of evisceration, which is one of the next few slides. So that evisceration is a step further from dehiscence. So dehiscence has occurred, and then what's inside comes out is evisceration. And again, it's usually abdominal surgeries that we're seeing that. Those are the highest risk. Okay, so if we have a dehiscence or we have an evisceration, we want to cover that with a sterile towel. So just like knowing where our equipment is in our patient's room. If it can be a sterile towel soaked with saline, that's even better. We just cover it, we call the provider, and then they're probably going back to surgery to have that fixed. It usually occurs in the first few days post-op. Alright, and then going through with our layers of the skin, so you have a nice picture off to the side of our 3 layers. So the epidermis is that top or outermost layer. It's waterproofed, and there's a bunch of specialized cells in there. And then the dermis is the middle layer. That's the one that's got all the blood vessels and nerve endings. So all like the nutrients and oxygen are carried to the layers of the skin through the dermis. And then the subcutaneous or adipose layer is underneath that fatty layer. Okay, so dermis, the layer below the epidermis. Okay, and there's also lots of connective tissue in that second layer. Okay, so when we went through aging, remember we talked about as we age, we have a breakdown of our connective tissue, and I said you guys connective tissue is everywhere in your body. Okay, so it's in that second layer of our skin. So you see the wrinkling and the thin layers of the skin as we get older. If there's anything else I wanted to say about that. Your TB tests that you give and that you get every year, those go into the dermis, so just under that first layer into the second layer. Send that So instead of extreme moisture leading to softening and breakdown, we can have extreme dryness to the point where their skin cracks open, and then now their skin is open, they don't have that first line of defense, and so they can get really bad infection and all types of sores, case of desiccation. Extremely dry to the point where now they're at risk for breakdown. Alright, and then our epidermis is our top layer. That picture is repeated there for you. I said that it is the protective layer, right? It's waterproof. It keeps things out that should be out and helps keep things in that should be in. And then there's 4 specialized type of cells in the epidermis that you want to know. So I don't know if we'll get to it today or next week, but on one of your slides, there's a question that's red. It says, what are the 4 types of specialized cells in your epidermis? So you want to know those. All right, and then epithelialization. So we talked about granulation. So granulation is like the filling in of the new tissue. It's a beefy red and it kind of grows from the inside out. Once all the granulation has occurred, the last step is epithelialization, and that's just the skin cells, the top layer of skin, just kind of migrating across the wound and closing it in. Okay, so granulation has occurred, it's all filled in, it's just the skin cells that need to kind of migrate across and connect. So each day that wound gets a little bit smaller. Okay, so from that first day, you can see it's totally superficial, it's barely has any depth to it, but the diameter gets smaller and smaller because that skin is growing across. Okay, so it's changing from that reddish color to like a pale pink. Okay, so those are just terms that you would use as you're documenting, like if you change a wound, if you change a dressing, you're documenting what you see, so you might use those terms. All right, and then erythema, you guys know, is redness. Okay, so erythema is redness. We're gonna see it when you have pressure in one spot. So like if you're sitting in one spot and you change position, you'll see that you have some redness, but it should quickly go away. And we talked about how in stage 1, they have non-bleachable redness. Okay, so non-white, it will not turn white. If you press the middle of that red spot on that heel over there, it would not turn white, it would just be red because the tissue's already dead. Okay, if it was just temporarily, like you or me, if I had my heel in one spot for 20 minutes, and then I looked at it and it was red, if I pushed in it, it would turn white, because I still have my circulation, everything is still perfusing, it's just a temporary thing. Alright, erythema, it usually does go with some swelling or edema, but not always, so you might see that. Usually goes with warmth also, temperature change, when you see swelling. It usually signals infection. So we talked a little bit before about how if the patient has surgery or trauma or some type, that first day, that incision is gonna be red, it's gonna be swollen. Okay, but it should progressively get better each day. And by post-op day 3, that wound should not be red anymore, maybe pale pink. Okay, so just knowing where they're at in the healing process, and then if they have a wound that has been, it's been 5 days ago and it's healing like it's supposed to, and then all of a sudden you look at it and now it's red again, now that's out of the time frame for natural healing, now you're worried about infection. Okay, so you're looking at some other things, is there more swelling, is the drainage different than what it was, does the patient have a fever? Alright, and then Eshkar, we didn't talk about. Eshkar is another term for that necrotic tissue. So the necrotic tissue is dead tissue, but the area itself, like the scab that you see, is called Eshkar. Thick, leathery scab or a dry crust. It is necrotic, so it's dead tissue, and it must be removed or that new granulation tissue cannot occur. Here's another picture of evisceration. So a lot of the pictures that you'll look are in babies because they're congenital. They're born with like different fistulas and different abnormalities of their GI tract, so that you might see it more often in your peds presentation. exudate is our term for our drainage, okay, so there's 4 different types, right? It's fluid that accumulates in that wound. It may contain serum, which is plasma, just like the watery yellow golden part of our blood. Cellular debris, bacteria, and white blood cells are all different parts of our drainage. So you can just see just different various colors and consistencies of our drainage. Okay, and then fistula, again, it's just an abnormal passage from an internal organ out to the skin, or from one internal organ to another internal organ. Okay, so internally. So if you have a patient who's had like multiple surgeries, they might get fistulas like between different areas of their small intestines or between their GU system and their GI system. Like you'll have patients that eliminate both things out of both ends because they develop fistulas from different complications. So fistula is an abnormal opening. It's also for dialysis, right? And for fun, things have multiple meanings, so it's harder to remember. But a fistula, so it's an abnormal opening. It's also the name of our dialysis site for our patients, a fistula. And it's the same thing, right? Abnormal opening between, if they open up the veins and arteries and connect them, which they shouldn't be. So it kind of makes sense that it's a fistula. All right, and then friction and shearing. So friction is just like if you slide up in your chair without lifting. Like if you scoot, you could cause a skin tear, right? Being young and healthy and having good nutrition, it's not likely, but a very old person, all it would take is just changing position. And if their skin gets stuck, they can cause that friction and shearing, and they can cause a skin tear just by changing position. And so that comes in for us when we're boosting our patients in bed. So we wanna always make sure we have a partner, we're in proper position, and we have a good grip on our equipment. We count to 3. We try to have our patient help us if they can by bending their knees and pushing off on their heels when we count to 3, giving themselves a hug, all of those things. Because if we don't incorporate them and have them help us, then we're more likely to just drag them across the bed, and then now we can open up their skin just because of the friction against the mattress. Alright, and then there's a picture of our granulation tissue, so you can kind of see like the little beads of tissue filling in. That's the granulation tissue. It's easier to see on that one. Maybe on your computers, you can kind of see the granulation tissue on the left side as well. There's a little bit. Okay, so as we would assess and look at this wound, these wounds both look absolutely beautiful. They're nice and beefy red. There's like a little bit of dead, dry skin hanging on this edge of that, but that's fine. So we would just protect this wound, keep it moist, and it's gonna heal in no time. It's good. Alright, hematoma then is a localized mass of usually clotted blood, but it's just like a big swollen bruise, right? It's a bruise that's got like some fluid to it. This picture on the top, there's a boxer or a fighter. You'll usually see at the end of a fight, they have hematomas, right, for getting punched in the face. So you'll see one up there. This one down here on the arm, it looks like probably an IV that went bad, and so there's blood collected under there. You can see the back of the foot here. Maybe they had some type of injury, and it was bleeding underneath the skin, didn't open, so it just all stayed under the skin. And then that last picture there is a picture of a hematoma that developed over a pacemaker site. So there's just a little incision up in the chest here, and they put that pacemaker, which is the electronic device that paces their heart rate if it drops too low. So they have a high risk, these types of patients, for developing that swelling of blood, that hematoma under that site. So we frequently have to assess for it. So they might have like a pressure bandage that we would put over that site to kind of help the body absorb that blood. If it gets really bad, just like an abscess, it would have to be drained. Alright, ischemia then, like we've been talking about, a deficiency of blood in a particular area. And then some of these images are just kind of reminding you of the different places that we'll see that. So this first one on the left is what we've talked about. So that's a picture describing a heart attack, right? So one of the coronary arteries that supplies the heart muscle itself. You can see see some plaque in there, and that area is kind of narrowed. So if we have ischemia or lack of blood and oxygen to the heart muscle, then we can have a heart attack. And then up on the right, that's an image of a stroke there. So if we have some ischemia in our vessels that serve our brain oxygen and nutrients, that would be a stroke. And then on the bottom, we talked a little bit about this with head to toe assessment. You'll go into PAD and PVD next semester. But same thing, if there's ischemia supplying our lower extremities, you're gonna see those weak pulses, the pale, cool skin, numbness, maybe tingling. Make a couple more vocab slides and we'll be done here. Here's a good picture of the maceration. So that top one, it just looks like they sat in wet socks, shoes for a long time. That might, you may have seen it like if you're in the bathtub for a long time and everything wrinkles up, that's maceration. Okay, so that's the top one, and then these other ones are both of wounds. So they had a dressing on this wound, but dressings are only good until they're saturated. And once they're saturated, it's doing more harm than good, you have to get it off. So that's what it would look like. You left a dressing on the skin for too long, and now all that drainage that we suck out of it is just sitting on it and it's leaking back in, so it's gonna cause more breakdown. All right, necrosis then, like we said, that's the cell death. Okay, so that black tissue. Negative pressure wound therapy, that's a wound vac. Some of you may have seen them in the nursing home or in the hospital, and that is gonna be for more than a superficial wound, a pretty deep wound, with lots of drainage or exudate. And we hook these up, and we change them every 3 days. And it keeps all the drainage off of that wound, and it promotes healing and growth of granulation tissue. Okay, between this week and next week, if you can, I know somewhere in here, there's a couple links. One of them is a video to a wound vac, and it kind of shows you how it works and the equipment and all that looks like. All right, and then our pressure injuries, which we're gonna go into detail next week. There's 4 stages, stage 1, 2, 3, 4. And then we just need to be aware of all of those high-risk sites, so places where our patients are lying and sitting. So the heels and the back of the head and the sacrum and the butt and all those areas that we wanna be looking for. Okay, and then here's just another image depending on how our patient is positioned. Okay, wherever there's pressure, and usually, on the other side of a bone, it's gonna be the other side of pressure, bone, and then the mattress, pushing on your tissues and your capillaries and your skin and causing that breakdown. Here's a picture of our purulent drainage, okay, so that's gonna signify infection. It's usually yellow, white, green are the main colors that we'll see, purulent drainage. Here's our sanguineous drainage, that is, blood, sanguineous, blood. Here's a scar, connective tissue that fills a wound, so you may have noticed these on some of your patients if they had a previous surgery, knee replacement or hip replacement, you might identify an old scar. And then our serous sanguineous is a mixture, so it's not just plain serum, it's not bright red blood, it's kind of in between, serous sanguineous. And then serous is just like the plasma drainage. So like if you wear shoes that are too tight and you get a blister, the fluid that's in there is serous fluid, it's serous drainage. Right, and then shear, we touched on with the friction slide, so it's the force that's created when your tissue layers move. And again, it's from sliding down in bed and then repositioning and boosting up in bed. Okay, and then our last vocab, our last slide for today, then subcutaneous tissue, which is that third layer that anchors the skin to the underlying tissues of the body, and then that's our fatty cushion layer. Okay? All right, so we made it through our vocab. We'll start on this slide 39. We'll start by going through pressure injuries, and we're gonna start with the worst, which is stage 4, and then we'll get to the least involved, which is stage 1. Okay, so we'll finish this. I'll have maybe a couple more activities for you guys to do, and then we'll have a in here on Tuesday. We do not have class Wednesday, okay?